Awesome. All right, so we're going to kick it off. So we're going to go through another case today. There's going to be incremental kind of points throughout the case where there'll be some definitely audience participation. So I appreciate hearing your thoughts as we go through this. So this is a 51-year-old female who had a history of a prior stroke with no residual deficits. She had an underlying seizure disorder and a history of Ranke's edema, vocal cord polyps, COPD and/or asthma without documented PFTs in the system, tobacco use disorder, and she presented to the ED initially with shortness of breath and chest pain. So on exam, you've got your set of vital signs. She is afebrile, 97.4. She was hypertensive on arrival, 173/112, with a respiratory rate that is being documented in the 20s and a heart rate of 112. And she's saturating already 100% on BiPAP. That was placed immediately. On exam, most notably, she is awake and alert, but being described from a pulmonary perspective as below. So she was noted to be tachypnic, using her accessory muscles, and being described as being in overt respiratory distress. Breath sounds were initially being described as, even prior to being placed on BiPAP, as what was being referred to by the ED as transmitted upper airway sounds. Patient not overtly stridulous, but did have some of what they're describing as transmitted upper airway sounds with breathing and no wheezing. Notably, patient did not have obvious wheezes on exam, but did have markedly decreased air movement throughout. So what are kind of your first thoughts when you're hearing about this case? You're going to get quite a bit of data in the ED course, and that's why I'm going to stop here for a moment, because they did quite a bit in the initial workup. But what are your thoughts when you're kind of hearing this case thus far, given the history and then the initial exam?
COPD exacerbation has an exacerbation.
What's that?
Like a COPD has an exacerbation without the wheezing because of the decreased air movement.
Yeah, I'm hearing COPD exacerbation potentially because of that kind of near silent chest that was being described. Is that right?
Yep, and an asthma exacerbation or status asthmaticus.
Yeah.
The upper airway sounds in the prior history could also be questionable for an upper airway type of obstruction from paradoxical vocal cord, or edema from that history of the Ranke's.
Yeah, exactly. So basically, this patient has multiple reasons that will leave her predisposed to have shortness of breath and perhaps related chest pain. But clearly she's in distress, and she's getting already some supportive therapies with non-invasive support. But the question is really, what's the major driver? How do we fix it? And how do we get her through this? Absolutely great thoughts there. That's exactly what the ED was also thinking when they first saw the patient. So then you actually were able to take a moment to review the prior hospitalizations, which is extremely important for a patient like this with this interesting history. So ultimately this patient had just been discharged from a hospital stay just less than 10 days ago. She had initially been admitted back in February with respiratory distress requiring an intubation, which then she suffered post-extubation stridor requiring racemic epi and ultimately reintubation. She then underwent a complex laryngoscopy with biopsy and injections of dexamethasone to the bilateral true vocal cords. And then actually they went back and looked again and debulked an area of her true vocal cords of this polypoid tissue and injected again, steroids again. And then most recently, she had just been admitted for worsening of what they were describing as Ranke's edema, requiring intubation for several days, with most notably a 5.0 endotracheal tube. So this is a patient who's had 3 prior intubations in the past 3 months and was just discharged from the hospital less than 10 days ago. So does that increase your suspicion for upper airway or kind of complicate the picture even more so?
Absolutely yes to both.
Yeah, exactly. Yeah, exactly. Because you're worried now, this is a patient who not only has perhaps some underlying obstructive, lung disease that hasn't really been fully differentiated, but also has high risk features when it comes to the actual vocal cords themselves. Plus, when you're mentioning, small endotracheal tube size and multiple repeat intubations over a small duration of time, you also want to think about the distance between the actual periglottic structures and the lower airway. Think about mid-tracheal stenosis, which can actually be a huge issue in these patients who had repeated intubations. Particularly, you can have dynamic collapse of the airway and as opposed to a more fixed obstruction, which would be led by the vocal cords themselves. So this could be really a multifactorial process. And part of what you're going to need to do is kind of get to the bottom of it. So a bit of detective work will really do you good for a patient like this. So let's go into what is this Ranke's edema. This is not something we're commonly ever mentioning in critical care. It's an ENT sort of familiar disease, but ultimately what it is, it's you may hear other terms being used. So I find that these terms are really helpful to be familiar with. So what is it? It's either referred to as polypoid chorditis, polypoid laryngitis, or degeneration of the vocal cords. So what's that?
Oh, nothing.
Sorry, Dr. Glaspey.
Oh, hello. Welcome to the party. We're talking about Ranke's edema. So what is this? This is actually a common chronic benign inflammatory condition of the larynx. It's involving congestion or swelling of just the subepithelial layer of the vocal cords. So what you might often have this referred to as, this is actually like a smoker's voice. It can be, it leads to increasing hoarseness or dysphonia, and very often in female smokers. So the first things that will happen is it's usually a chronic smoker, usually a female, and they'll first just have sort of loss of the higher range vocal cord, of higher range of sort of voice range, vocal range. And, this is actually, they'll usually sound, if they were on the phone, they may be mistaken as a male voice on the phone. This is kind of your common first sign. But it can lead to life-threatening edema of the vocal cords and periglottic structures. But it is most commonly not that. It's usually managed as an outpatient setting. They may be biopsied, once at some point just to make sure that, because it's usually associated with smoking, they'll make sure there's no malignancy. But usually this is a benign condition. What do they do to treat it? So number one is stop smoking. That's the first thing they'll tell everybody is please stop smoking. They'll start everybody usually on an anti-reflux medication. Voice therapy is often provided for those that the cause was things like overuse. So for folks that are professional singers, this can also affect them as well. Although, again, the number one population is usually smokers. And then the last line will be something like surgery, but it is not commonly requiring surgery. It's usually very effectively managed with the first line, therapies, including just smoking cessation in those who are smokers. So this is the patient's chest X-ray. Any thoughts?
Yeah, it looks fine.
Yeah, looks pretty good. Yeah. So here's your EKG. Just sinus tachycardia, maybe a little bit of a prolonged, go ahead. I heard a voice there.
No, I was just saying it looks okay to me. I
Yep,
agree
yeah.
with you. Borderline prolonged QT, but otherwise it looks fine.
Yep, exactly. So here is your blood gas. You got a mixed venous and you got a venous blood gas in the ED. Thoughts on this?
Yeah, so acidotic, CO2 is elevated, so we have a respiratory acidosis.
Yeah, and it's acute. This is the pH 7.29. This is an acute hypercapnic respiratory failure or hypercarbic respiratory acidosis. So yeah, this patient is being supported with BiPAP very appropriately. Sounds pretty reasonable so far. And then they also cycled troponins because there was this complaint of chest pain. They actually were negative. High sensitivity tropes were negative ×2. Otherwise, their CBC and BMP were all completely unremarkable. So the ED team actually already phoned a friend. So given those really high risk features, that before you had ever been called, there was a call to the ENT team to come down and take a look at these vocal cords. You know, they had just operated on this patient, seemed super reasonable, right? So they came down, and here is the actual only data you have available. So unfortunately, you're not able to objectively evaluate the images that the ENT team captures. This often happens, and so you'll just have basically a report of their interpretation of it. And I'll highlight kind of the most notable features. So they performed an NPL, and they found that there was mild, so the epiglottis was normal, no masses or lesion. Around the aretinoids, they were considered to be normal with some mild erythema and edema, normal vocal cord mobility, no evidence of Ranke's edema or polyporditis within the true vocal folds, and no true vocal fold edema. The left true vocal fold had some anterior rounded polypoid mass, but it was non-obstructive, and they're definitively saying there's a patent glottic airway. So ultimately their interpretation was patient is able to be orotracheally intubated if needed. There's a considerable improvement in the appearance of the bilateral true vocal cords without significant edema. They are saying this is due to pulmonary causes. You know, basically don't think of this as being an upper airway problem. So you are now called. You have that data coming into this situation. So what do you think would be your first steps in management in this patient? I picked a tricky one on purpose.
Honestly, ideally, try not to intubate.
Yeah, absolutely. So the crux of it is you are saying, hey, I know what they're saying is that there's an upper airway that's patent, but I'm really worried, you know, and so and acknowledging you don't have direct visualization of what that MPL showed. So you're still getting secondhand information of someone else's interpretation. So just as you had mentioned initially, the ED team was also concerned for a possible, COPD versus asthma overlap syndrome. And so the patient had already been given 125 milligrams of solumedrol. They had been given multiple duonebs and just was started on some Q2 albuterol. And the patient herself is, able to, partially attempt phonation behind BiPAP mask, is, as compared to what the ED described initially, is in a relaxed posture, is now heart rate's coming down, and she's able to nod and tell you she feels much better, but certainly isn't out of the woods, but she feels a lot better with the current supportive therapies. So you can at least say, okay, this patient doesn't need to be intubated, which is great at this juncture, but we really still have big questions of how are we going to get her better and what's going on. So what would be your next steps? Because this is truly like a less of a emergent management and more of a true critical care case we're going to go step by step with. So what would you want to do to further clarify what's going on with this patient and how to get her better?
Oh, I see you.
You wanted to come to the ICU? Was that
down to the ED, you said call ICU.
Yeah.
Sorry, Dr. Glass, did you say that you have imaging on her on this admission?
No.
Other than the chest x-ray?
No, would you like imaging?
Yes, absolutely.
Awesome. Would you like a CT of the neck, perhaps?
Uh-huh.
Great, awesome. So I just learned how to do this for the first time. I made a video, so hopefully this works. It might be fast, but I'm gonna go through it a couple times. So here is your CT of the neck. I'm so happy this worked. It made me so happy. We're going to go through it a couple times and I'll toggle through. I didn't know how to make it loop. We got so close. So just looking at that quickly, what are you thinking so far?
So I see upper airway edema, which I guess isn't surprising, but it also looks like it narrows and then flares out. So I wonder if there is a component of stenosis, or wait, hold on.
I'm going to go to a couple critical junctions and you tell me what you're seeing, because this is really, it's pretty interesting. So, okay. So, okay. It's pretty patent, right? But then you're getting into here, right?
Yeah.
Yeah. Are you worried about that?
I'm not sure that a 5.0 would fit into that.
Right. So I'm going to tell you something really interesting, which is why, I'm so happy you're getting every step of this, because this is why you look at your own images.
Yeah.
So let's skip to the read. So long story short, in the impression at the bottom, I know it's a lot of text, but I'm going to point out the important parts, which is that the impression is really there's just a small left anterior vocal cord soft tissue lesion, probable residual polypocarditis, and there's no laryngeal edema or airway obstruction. And there is no comment of that narrowing that we were kind of talking about, right? So first things first is in the findings, they do acknowledge this examination is degraded by patient motion. She's basically moving a little bit, and so I do not think they were calling that bit of narrowing that we saw because they thought that was limited by motion. But essentially this was read as completely patent upper airway. Normal nasopharyngeal or pharyngeal hypopharyngeal airways, normal epiglottic and area epiglottic folds, mild stranding within the false vocal cords, which was similar to the prior scan, and that the piriform sinus and vallecula are widely patent. So basically, they're not seeing what we're seeing, right? Because this is the point of why, you're seeing the patient in front of you. It's so important to correlate that clinically, which is, it's the age-old thing, radiologists said, is correlate clinically. But you really do have critical factors when it comes to both assessing the patient and you have the history that they just don't have. So I agree. That was not captured on the initial evaluation, but I agree with what you were saying. You were already worried. Now, granted, in the grand scheme of things, there is an airway. It's pretty good. It's a lot better than you would anticipate, but there is definitely this narrow. This is all patent. But just around here, you're getting to that a subglottic component, and it's getting quite narrow in here. Yeah. But I think that they weren't calling this because you can see this is motion degraded a bit. So yeah, lesson number one in this is definitely look at your own images and just to give the full sense of what's going on. Okay, so hospital course. So first day, we're doing all the things that she initially, you were initially recommending. She was on BiPAP. She required a little bit of Precedex because she understandably had quite a bit of anxiety associated with her dyspnea, but it was a very, very low dose. And she got a repeat blood gas, which looked perfectly fine. By the next morning, yes, can you hear me?
So I have a question. In terms of her BiPAP, like when she's ventilating right now, what are we seeing in terms of the actual loops?
Oh, yeah.
And the factors?
So I'm not going to give you that because we're going to have some other factors that are interesting along the way. But let's just say nothing ever alarmed, nothing was a problem, and no one ever drew your attention to anything. That's what I say is the most notable thing. But that's an excellent question. And basically she felt better. Your blood gas looked fantastic, perfectly normal. And by the next morning, she's off BiPAP, and you had asked for pulmonary to see the patient. So they are involved because we talked about the first component. We got some imaging because we were worried about that upper airway, both from a direct visualization from an ENT perspective and then from a CT perspective. So we got those two pieces of data. But then the next point that you all mentioned right from the beginning is this patient has some underlying obstructive lung disease that's being commented on, and we don't really have that fully elucidated yet. Okay, so pulmonary saw the patient and they said, we're going to get full PFTs to assess the degree of asthma. Her wheezing appears more upper airway related. Furthermore, her hypercapnia is acute. So she was being treated for asthma with standing Duanebs, Pulmicort. She was on steroids already, which we were going to finish. She had been empirically given doxycycline for 5 days due to an azithromycin allergy and the question of whether she had an underlying COPD component. And then the thought was that, this was related in part due to her Ranke's edema due to smoking and GERD. So, day 3. She has this continued sort of just hoarse voice, but she's on room air. She's not even on supplemental O2. She is able to actually get up and ambulate, and she was able to go to the bathroom by herself. And the nurse is like, why is this patient in the ICU? Can I transfer her out of the ICU? And what is your thought process on this?
I would prefer to
Stable, but very high risk.
Yeah, exactly. Yeah, I agree. I heard the first part of what Feba was saying, and then whoever chimed in. Sorry, I can't see the. So you're saying not yet?
No.
No.
Yes.
No. Other thoughts on that?
A patient like this, this is just my preference, would be optimize her until she's ready to go home. And when she's going home, I just prefer to discharge her straight from the ICU because I would not want her to be in any way suboptimal going to a different level of care where an acute airway is going to be her major issue.
Yes.
Where the resources are not available.
Yeah, absolutely. Because you've
I don't know if
already.
that's just being overcautious.
No, I think it's an excellent thought process that incorporates, unfortunately the nurse who's saying this doesn't know the whole history. So they're very reasonably saying, like, why is this patient requiring the ICU? And your answer is to really explain the complexity of her care and also an unclear trajectory. This woman has been intubated 3 times in the past 3 months with extremely difficult intubations. She was intubated with very small endotracheal tube each time, which was a 5.0 or a 5.5, I think was the biggest she ever got. And so this isn't someone who even, could be rescued in a very routine manner outside of you having the context of this patient. All these details. If anything happens outside of that care without a clear, understanding of what her trajectory is, she's really put in a bit of a pickle. So you're gonna keep her in the unit, and you're gonna be so thrilled you did by day 4 because, oops, sorry, here. Oh wait. Okay, well, we'll say. But the other reason I wanted to point out, sorry, was that the plan was for the pulmonary team to do inpatient PFTs. And so the question is can that sometimes be a trigger for patients?
Yes.
Yeah, absolutely. So my thought process, I didn't care for this patient in the very beginning, but, at this point, the concern is that you really don't have a clear diagnosis, a clear trajectory, and you're going to be potentially doing something that would leave this patient more vulnerable with an increased respiratory effort just when they've finally started improving. So on day 4, you get PFTs. What do you think of this?
It shows an upper airway obstruction.
Yeah. So as a reminder, so thank you for jumping right to that. But no, it's perfect. No, so it's showing evidence of, so on the left-hand side is her flow volume loop. And on the right-hand side is some reminders of what some comparisons would be when you're evaluating PFTs. The point of this talk is not to go into detailed PFTs, and I'll leave that for Dr. Bunk. But the core pulmonologists of the group. But what is this flow volume loop look exactly like? It looks like a fixed upper airway obstruction. It is nearly identical. So what you're seeing is that this is both an inspiratory and expiratory flow problem, and it is quite fixed. It is exactly the definition of that. Exactly. So you have additional data, and so then next steps. Yes, so it's still this day 4. PFTs are demonstrating a fixed airflow obstruction. So now pulmonary team, yeah, the pulmonary team consulted interventional and they were like, hey, we'll come by and just do a bronch at the bedside if you just serve as standby as the backup. Do you have any questions or concerns? By the way, they were already scheduling this as you found out about it.
Yeah, we need like 3 other hands in here, including anesthesia, trauma for a surgical airway. A lot more.
Yeah, exactly. Yes. Yes. So I think that, it is, again, that it is so easy to focus on just one portion of this and not look at the big picture. Our job, if there's one thing that I ever teach you, hopefully it's probably not going to be the PFTs, but it's going to be your job is to be the quarterback of the team. And so there's going to be a lot of people coming in and having a lot of things they want to do with your patient, and taking some significant ownership of what happens next for that patient will do both you and the patient right. So yeah, the answer is no, we're not going to do, a typical bit of a touch of fentanyl and Versed, which was their plan, and bedside bronchoscopy, for this evaluation. Of note, at the bedside, it would truly be just diagnostic and not otherwise therapeutic. And so this patient would then be left in an increasingly vulnerable situation with you as their backup, which ultimately, you guys all got immediately with the giggles, which is that's not a good plan. So the answer is that's not happening. And you're happy you decided to do that because overnight she developed acute distress with increased dysphonia, stridor, and increased work of breathing. So what are your management options now for this patient? And you can ask more questions about like what she looks like so that you find the right answer.
Was this post PFT or attempted bronch or anything else?
Excellent question. She had gotten the PFTs performed during the day and had returned with no incident, no issues, did fine for many, many hours. This overnight update probably occurred at like between 2 and 5 in the morning.
How's she looking on the monitor?
She is tachycardic and tachypnic, but she is saturating 98%.
Do we have another ABG?
You do not.
Did she have any new medications started on her acutely as well?
No new medications.
She's still on the BiPAP?
No, she had been on room air. So if you would like to get BiPAP, absolutely. Yeah. Do you want to get BiPAP?
Yeah.
Yeah, sounds good. I like it. So we're going to do BiPAP. That sounds super reasonable.
I would probably, if I'm worried about, sorry, Stanley, go ahead.
No, go ahead.
No, I was going to say at this point, I mean, the questions I have is, does she have any risk factors for worsening edema and or a role of either steroids or racemic epi if we're worried about something happening to her vocal cord or that polyp that she had there?
Yeah, so she had been on a slightly decreasing dose of steroids. So if you want to give her another dose of steroids, super reasonable. And then you're mentioning whether the question is this coming from the obstruction itself? What are 2 different inhaled medications that potentially could help almost nearly resolve her work of breathing?
Either racemic epi or Heliox.
Yeah.
We could probably do racemic epi or Heliox for her. I was just going to ask also, like, if she, so in this setting with this happening acutely, I think my primary concern would be, one, what options do we have to try and obviously oxygenate her and how much is she requiring? Intubating would be very complicated. So I think I would in this setting, I would probably not hesitate to start calling for backup to mobilize people, especially if it's in the middle of the night, because they might take some time to get people there. Yeah. And it's better to get that plan started early as opposed to waiting until the last minute trying to rescue her while we're initiating the medical management at that point.
Yeah, it's never wrong to phone a friend. But you also want to be obviously at the same time directly addressing her symptoms. So that's exactly it. Because that part takes time. The phoning the friends part definitely takes time. And so in this case, You would not be wrong by considering something like racemic epi. So what would racemic epi potentially help with?
It just helps with like laminar flow.
Well,
edema.
not the racemic epi. Yeah.
My bad, I was talking about the Heliox.
Oh, sure. Yep. So Heliox is it's going to improve laminar flow, so make it easier for the patient to essentially ventilate. Oxygenation is a major barrier. This patient was saturating perfectly fine. She was saturating 98% on, room air before everyone came in and started applying oxygen. So actually, she's a perfect candidate for Heliox. And why might that be best? Well, racemic epi has very limited ability to modify this clinical scenario. So systemic steroids, very reasonable. Although again, this edema is not generally super steroid responsive, under what you think is the primary cause. Now consider there can be multiple, but she does have the underlying history of this Ranke's edema. Could she then develop another component to this? Absolutely. But we had already mentioned we're worried about multi-level stenosis. So not only at the vocal cord level, but some subglottic stenosis, plus potentially, we didn't get to go through like a methylcholine challenge, but she may also have an underlying reactive airway process as well, all of which would be improved with Heliox. Particularly because oxygenation was not an issue. So that was actually what the team did overnight. She was put on Heliox and she immediately felt better, like immediately. It was, it was pretty incredible. And she's like smiling. She's like, for context, this woman is the sweetest woman ever. And she just was like so happy. And you could tell when she felt, not well and when she was feeling great, but she was double thumbs up, feeling great on Heliox. So you are now, you are now seeing this patient in the morning after those updates. So, now what you have is that this patient now had an acute clinical status change, now has an increase in their support they require. It is because of largely a ventilation failure. It was not an oxygenation failure. She was struggling to really get air in and out, and now is remarkably improved on Heliox. Like she feels very, very comfortable. What would you like to do as your next steps or consider as part of your next steps?
I think part of the problem here is, one, what caused her to go into a repeat exacerbation, either of her underlying lung disease and or confounded by the upper airway issue that laminar flow is helping her? And how can we sustain? Because Heliox is not a permanent solution.
Exactly. Yeah, it's worrisome, right? I mean, you did the right thing and you're supporting her physiology, but I think about Heliox as like, this is your rescue answer. It is not your solution. You are supporting her while you get to the bottom of what is the modifiable factor I can do to get her better and get her out of the ICU and in a good quality of life, thriving. This is not it. So you fixed it temporarily and she feels great on Heliox, but that's not the answer long-term, right?
Yeah, I don't know if this is the right answer, but at least the way that I'm thinking about this, if we're doing upper and lower airway issues, is does she need a way to bypass her either stenotic area or the area of her upper airway above the carina that's has the polyp and edema? She needs surgical or a trach at this point that needs to be done in the OR, not bedside. And then thereafter, treatment for her underlying reactive airway or COPD with aggressive medical therapy. And I don't know that, I don't know how we would differentiate that, but that's at least the way that I'm thinking.
Yeah. And as we, sort of started this case, you knew that you had ENT in-house. You also have, pulmonary, interventional pulmonary. You also have thoracic surgery in-house. So ultimately, ENT, pulmonary, including interventional pulmonary and thoracic surgery, have been looped in and evaluated this patient. And everybody says, well, why don't you just get another CAT scan? So things could have changed. This has been 5 days now. I know it was not really clear because this was like day 4. So this is day 5 now of her hospital course. why don't we just get another reevaluation? Things could have changed, which is not unreasonable, right? So here is your repeat CT neck on day 5. Now, granted, just to recap, you have now the only change in her care is that she's now on Heliox, but otherwise she had been continued on steroids, nebs, and that was essentially it. I'm going to go slowly. Okay, so it's pretty fast at first, but just so you can see it a few times. So let's go to this one where it starts at the top here. Okay, what are we seeing right here? Oh, geez. Oh, no. Ah! No! That's what happens when you're trying to do a video. Hold on. Oh, let me see. Hold on. Share this way. Let's see. Yeah.
This is a really good case.
Oh, wait. Is this not? Oh, God. Stop sharing. Hold on. Let me try it this way. Give control. Wait, what? Ah! Reshare. Let me try it this way. Can you see just the slides?
Yes.
No.
We also
see
see
it.
Yeah, hit that button right there. It should
Okay.
exactly.
All right, cool. Well, let's try not to. All right, it works better if I do the video, but then you can't see everything slowly. So next time I'm going to try to do half speed. Okay, so all right, let's go here. All right, what do we see? I'm not going to point because that ruined it. Okay, what do we see here? Obviously, we're focusing on airway structures. Ah. So you're seeing the level of the epiglottis, right? So you want to orient yourself. Epiglottis. Okay, you're coming in. Now you're seeing the area of where the vocal cords are, right? So there's still a patent glottic opening. I agree. Okay. Then you're coming down, down, down. Uh-oh. What's that? Are you happy or not happy with that?
not happy.
Yeah, me either. I wasn't happy at all. No, was not.
It's almost like deep into the trachea. That's not high into the airway.
Yeah, which is like the worst thing to see, right? So that's not good at all. Okay, and then you come down and okay, and then just above the carina, it's perfectly fine. So let's see if we agree with the interpretation of this CT. Okay, turns out we do. Overall impressions, there's severe focal tracheal narrowing with wall thickening, most prominently anteriorly at the level of the thoracic inlet, which was exactly what we were really seeing. There's mild narrowing of the glottic larynx with a tiny nodule. I didn't point it out, but it's not very big, along the left true vocal cord. And then if we go back to the body, which you should always, always, always look at your own images every single time and always look at the actual body of the interpretation of the scan. And it'll show you that they were measuring this. And at the level of maximal narrowing, the lumen measures 7 millimeters in AP dimension and 5 millimeters in a transverse dimension. I challenge you to, when you next have access to a ruler, look at 5 millimeters on a ruler. It's small. It's certainly smaller than an endotracheal tube, right? So you're already really extra worried, and you're actually quite happy that you repeated this imaging because it gave you some additional data that makes a lot of sense, right? So you also, again, I told you, we called the cavalry, we phoned all our friends, and you asked for a repeat MPL, and this is now what you see. So I sat at the bedside because they usually run away, and I said, I need to see the imaging because the interpretation that our colleagues are often doing is very different than our interpretation of an airway. So are you, let's orient ourselves a little bit. So let's talk a little airway anatomy. What are you seeing? So this is on the screen, right? This is almost exactly what this patient had. I actually didn't get their image, but this is what I found on the internet that is almost exactly the same. So you're deep to the epiglottis. You can't see where the epiglottis is, but what you are seeing is, can you see my mouse? Is that working?
No.
Oh, darn. Okay. Well, on screen, right, you're seeing clearly these big blobs of clear fluid, right? So that's actually big polyps, edematous polyps that are on the vocal cords. So the true vocal cords. If you want to, again, to orient yourself, sorry, I wish there was a pointer, but so you'll see the true vocal cords on screen left is the only way you can really orient yourself to normal anatomy. True vocal cords are sort of what you would consider the periglottic opening. It's right there, adjacent to there. Then moving outwards from medial, you'll see the false vocal cords. And then outside of that is the area epiglottic fold. So in interpretation of this, you're seeing profound edema of the area epiglottic fold, extending to the false vocal cords, true vocal cords with bilateral vocal cord polyps that are near completely obstructing the glottic opening. You can say there is a pencil-sized opening of the glottis in the most posterior aspect. So, yeah. So what you're going to get from ENT is going to be there's a patent glottic opening.
Oh, wow.
Yeah, and that's why you got to see these images and get used to seeing them. So, when I was practicing emergency medicine exclusively, I did all my own MPLs, but we just don't have that practice because of ENT in-house, and they, it's sort of the expectation that they are doing them. The downside is that it is often hard to just coordinate and make sure that you are seeing those images because they don't go into the chart. And so you either want to, coordinate care and be at the bedside, or try to get screenshots or something, because it really does change your management, because a picture is worth 1,000 words, in the way that a description in the chart is not. So I'm sure as soon as you guys all saw this, you were like, holy smokes.
What is the approach to this? I mean, she has upper airway and on that CAT scan, lower airway.
Yeah.
Not lower, but
Yeah, essentially where the endotracheal tube cuff would sit is where you have sort of the most significant narrowing. So now, to recap, you have someone who has multifactorial dyspnea and respiratory failure, now on Heliox, currently clinically stabilized imminently, but really without a clear out. So the reality is that all of the teammates had seen this patient and said, basically, you're doing great, keep it up. And we would potentially, this is on a Friday, naturally, as all my major events occur. And they said, next week we'll consider booking her for an awake bronchoscopy in the OR, which would include both IP for evaluation and then potentially thoracics involved for basically dilation of the trachea, because they were also concerned that it was really at the level of the trachea that was the more significant component of this. And again, ENT is sort of evaluating this and saying, like, patent glottic opening, nothing to worry about from our end. So that's what you're left with. So, again, you're the quarterback, you got a lot of teammates, they're happy to help, but, none of this is emergent in their eyes. They do all sort of, routine stuff. You do the emergencies. So what would you like to do?
Keep her on Heliox until all the swelling resolves, because I was just talking, I was just saying, like, what do we do if we have swelling lower down?
Yeah.
And anything that you put there, I don't know what the exact pathophys and the etiology is, but there's nothing to say that if you stent open that specific area lower down, that you can somehow bypass the upper at the glottic level.
Right,
that
because
you're
the
going to be
ways
able to bypass the lower.
Right, because the ways that you would have to do that would involve tools that we just don't use. So things that can do that, it would be tracheal dilators. You can use things like laser ablate, like cryo and laser ablation. Usually it's lasers, but those are all tools we don't have. The only thing we have is like brute force, basically, which what all that causes is bleeding. So bleeding and trauma to the trachea is a terrible disaster. So yeah, you're appropriately recognizing that this is sort of an impossible scenario because it's largely a structural and a surgical process that I can't fix. So ultimately, unfortunately, things kind of came to a head. So she developed diaphoresis. What do you think about diaphoresis? That's the only thing that changed. She otherwise is saturating 100%. She is saturating 100%. Her heart rate has been, like like below 110, nothing wild. She's not profoundly tachycardic. She is just diaphoretic. Like her hair is saturating, her wet hair is saturating her pillow.
Impending doom.
Yeah, exactly. 100%. So diaphoresis is a vital sign. If I teach you nothing else, this is my parting talk for the fellows that are graduating. So I'm putting in all of the things that I've wanted to say forever, but diaphoresis is a vital sign. If someone is sweating, that is a problem. And why does this make perfect sense for this patient? It's because she is never going to be hypoxemic. That is going to be the absolute last stage. You may even see bradycardia before you see something like hypoxemia in this patient. So you really don't want to sit on something like diaphoresis. So let's talk about what you have to do if you have to secure this airway. Because everybody left for the day.
Call one back.
No more backup.
Yeah, absolutely. So I will cut to the chase, which is that I did exactly that. And I leveled this patient to the OR with trauma surgery. But we're going to talk about it for the sake of learning points of what you're going to do. You can consider something like an awake fiber optic intubation. So what does it require? It requires a pep talk. So it requires quite a bit of preparation, and you need to give yourself the heck of a pep talk. You need the right patient, meaning they need to be cooperative, and you need to have what I refer to as the perfect storm of a extremely difficult airway characteristics, which this patient has, but also time. So you need to have some degree of time. So I would put on the spectrum of right patient would be someone who is definitely a right patient, would be someone who has like a head and neck cancer. The absolute worst patient would be someone who has anaphylaxis. So they have upper airway compromise, but that's happening fast. Time is not on your side. So you need to have a cooperative patient who is able to be involved in this process. And you need to have a disease state that is tolerant of time, because it takes a heck of a long time to get all this equipment. So right patient, right equipment, you need to have the right drugs and tools. So if you do not have the right drugs and tools, meaning like I've had situations where I've wanted to do this and there's one tool missing, guess what? You can't do the procedure. So you need to have the right drugs and tools, and you need to have the right people. And I use team to remember the talk part. So right people, that includes having backup. But right people meaning that also includes you and your skill set. Again, I'm doing this talk for the people who are exiting us and will only see me in passing, or they're gonna, just like text me when I'm on Atlantic Care Nights. And so you are included in the right people part of this, which means if you're going to be approaching your second awake fiber optic intubation, well, maybe this isn't the time to do it with no one else around. So, maybe the time is to, phone a friend and do it with them for your second or third or fourth until you feel more comfortable. So you need to have the right patient, right equipment, and the right people. And that includes you. And so if you have those pieces in place, then you can consider this procedure. So some quick and dirty things you need to consider in the airway checklist is you have to be able to pre-oxygenate these patients. So this gets missed all the time because you're worried about gathering your drugs, you're worried about gathering all of the equipment, and everybody forgets that the patient in front of you, you have to pre-oxygenate them during the entire time that you're gathering all these equipment. You want to dry them out. That's something like glycopyrrolate, and give it early. It takes like 15 minutes to work, and at least. And so I'm giving it like first and foremost. The moment that you're potentially deciding to do an awake fiber optic intubation, you're going to give them glycopyrrolate really early, and you're going to start pre-oxygenating them really early. You're going to topicalize. There's a million different ways to do this. We've talked about it a couple of times with Jared's talk too. My preference is you pick one way to do it. You just do it consistently, depending on the availability of these supplies. So, anesthesia, they'll use this viscous lidocaine lollipop. I've never found that in my entire life in the entire hospital. So I'm personally doing a directed dose of lidocaine sprayed into the posterior oropharynx, or if I'm using the nose, I'm going directly into the nares, and I'm using the viscous jelly. And the reason why is that that's something that basically kind of like marinates back there, and it sticks a little bit longer than the solution, which will just kind of fall off the mucosa. And so the viscous lidocaine plus a directed dose of lidocaine can be really helpful. Then you're going to consider your sedation. So that is something, again, I find it is really helpful to think through this in advance and choose what you want to do. For me, every single time, I'm not going to deviate. I'm going to do something like a little low-dose Precedex in the background and ketamine. I do not like to use benzos. They're quite unpredictable. I really do not like them. Doing this, many times with many patients. Some patients, you give them like 1 or 2 of Versed and they're completely unconscious. So you're no longer doing a twilight or a light sedation. And you don't always need to sedate them. So the most recent patient I had was an extremely cooperative head and neck cancer patient who we were able to talk through all of this before. And literally the only thing he had was topicalization, and Precedex was at 0.2. So you don't always need to do the ketamine part, but it can be helpful to get folks through it. You're going to position them and intubate them. When you are doing that, if you're going to approach the oral, an oral approach, consider this a piece of equipment. What's the name of this? Because no one's going to know what it is when you ask for it. It's an intubating oral airway, or a Williams airway. Really important. It's really the only way that you can intubate orally in a fiber optic approach. Why? Because they're just going to bite down on your scope, and it's going to be extremely hard to navigate the oropharynx. And then confirm placement.
Mark have those, by the way, but you have to know to ask RT for them because they don't really use them anymore, but they're like locked away into the recesses of the hospital.
Yes, and that, in my experience, the locked away portion is everywhere. So I may or may not have a. I get these almost every shift, and I just put them in my pocket because they are impossible to find, and they unfortunately are often, when I talked about right pieces of equipment, this is sometimes the barrier to being able to choose an oral approach. And I would hate that I can't do this because I just don't have the right tools to do my job. So, okay, so this was just the quick and dirty as a reminder of how we can approach an awake fiber optic intubation. Ultimately, I would say always consider, no one ever talks about this as much, but consider an alternative approach. Again, if you are unable to call a surgeon and call an anesthesiologist immediately, consider topicalization with a video laryngoscopy with a head of bed elevated as high as possible. So you want to avoid doing something that is super high risk that you have limited comfort with. So again, if you have done very few awake fiber optic intubations, choose to intubate in the way that you know how to do it best, but just include things like topicalization. And so I have found that is an excellent alternative. And it often gets missed because folks will only think about RSI as one extreme, and then complete awake fiber optic intubation sitting upright with an oral intubating, bronchoscope as the only other option. There's an in-between option, which is topicalization and using the same medication, same approach. You're pre-medicating with the glycopyrrolate, you are topicalizing like crazy, but then you can use something like a video laryngoscope. And again, using the head of the bed elevated as much as possible for the patient's kind of comfort, and to be able to facilitate it that way. That is another option. Ultimately, this patient went level 0 with anesthesia and trauma because I literally just called the trauma attending and I said, I need you to level a case. And to their credit, I have to hand it to them. They had never even examined my patient. All I did was call and I said, I need you to level a case. And they picked up the phone and leveled the case without even knowing what I needed. So I have so much thanks for their trust in the care that we provide, because they actually, this attending leveled the case and opened an OR before even seeing the patient. And then we walked together and escorted the patient to the OR. And I'm really happy we did, because the follow-up is, guess what? Anesthesia was unable to intubate this patient. They did that entire step we went through. They did the topicalization. They attempted, they said they, passed the tube through the corbs, but was unable to pass through the stenosed area. And ultimately, the patient required a successful open tracheostomy. And so everything went amazingly well, all things considered. They were able to sort of dissect past this severe tracheal stenosis that the tube was unable to pass by. And so they were able to perform a successful open tracheostomy. Okay, so follow-up. Since we are approaching the end, perfect timing. Okay, so follow-up for this patient. So just last week, we had gone through, I think it was last week. We went through the video that Emily Damuth gave for trach emergencies. I was going to include that in this talk, but I pulled it out because we already did that last week. But ultimately, I was going to mention that she suffered the most common complication that occurs when a patient gets trached. And she had a trach dislodgement within the first 7 days of her receiving a successful tracheostomy. But she had it uneventfully reinserted by bronchoscopic guidance. And then 20 days later, after admission, day 20 of her entire hospitalization, she was actually transferred to Penn for possible tracheal reconstruction. And I didn't think that was required, but the thoracic surgery team was, insistent for this evaluation. And they said, no, Dr. Glaspey's correct. The patient does not need a tracheal reconstruction. So she returned without any intervention, and she went home and is doing amazing. And on her day of discharge, I had the chance to talk with her, and she asked that I give this talk. And she asked to be invited back when she has her voice to be able to share her story and her side of this, because obviously this was a harrowing, respiratory emergency. And she was really excited at the prospect of folks learning from her really complicated case. So yeah, she went home, she's trach, she's just on humidified O2. She never required any intervention for the distal stenosis. It truly was probably all related to the upper airway component. And it was just made worse by the fact that she had, the distal component as well, and which is what made it so hard for them to pass a tube in the conventional sense. It probably was, the tracheal stenosis was probably around the area of where her cuff had sat during her prior intubation. So she probably had some subglottic stenosis from that perspective. And then the primary problem was largely her Ranke's edema, because as soon as she was trached, she was perfectly fine. She gave us hugs and was completely, she had no symptoms, completely resolved everything. So my last take-home message is, you're going to have a lot of brilliant people tell you what you need to do for patients. But ultimately, you are going to be the captain of the ship. And so I would encourage you to 100% listen to the most brilliant people that you know, but also look at the imaging yourself, look at any tests that are done yourself. I think what really changed a lot of this was direct visualization of both the, repeat CT and then her repeat MPL, kind of clarifying the picture and diagnosis. So don't be afraid to, advocate for what you think needs to be happening for a patient, and you guys are going to be hopefully not in a pickle without that trauma surgery backup, because I'm so very thankful for them. And that's it.
Thank you. That was a great case.
I got a quick question, Lindsay.
Yeah, please.
So they dissected down through the area of stenosis where she had it in closer to in the proximal trachea, when they put the tracheostomy. In terms of her chances of decannulation, what is she looking at?
So that's what we talked about, because the issue is she had already undergone. So if you look at just not the tracheal component, just at the vocal cord component, she had already undergone basically the 2 rounds of the dexamethasone injections, and then the next steps are like full basically laser ablation of the vocal cords from an upper airway perspective. And then the issue about, which is why the thoracic team was encouraging basically full reconstruction evaluation, would be if she's going to be liberated from the tracheostomy entirely, she would have to basically have that tube out for an extended portion of time and then have a complete reconstruction of that where the actual tube is located, complete reconstruction of her trachea. And ultimately, even if that was offered, the patient would say no. She was absolutely not. So I think the number one thing is resolving the life threat, and now she can live about her life perfectly fine. And then the next thing will be ENT and follow-up to resolve the upper airway component, because why would that be helpful? She might even be able to phonate now, meaning, so she's already has an uncuffed trach, and so she might be able to just actually generate normal sound, which would be, again, all about quality of life and what would be the most important to her. But as far as the actual level of the tracheal stenosis, that would require there being a team that actually thinks she needs full tracheal reconstruction, which they did not. They were absolutely not. They wouldn't touch this.
So more than likely she'll remain with the trach, but able to with the passing about being able to phonate.
Yeah, I think she'll be able to phonate. I mean, that's what I because that's what I would root for her, and that's what I talked to her about, and that's why she didn't want to come to see you guys until she had a voice. So yeah, she was like, I want to be able to use my own voice. Right now she's just writing on a giant board and and typing things out and getting used to that. But yeah, I mean, it was I think that's a very good question, but I think right now it would be all about healing and getting that through the first phases of her recovery. But again, Penn basically said no. They were we would not offer this. This would be exceedingly high risk with limited reward. Yeah.
Makes sense. Thank you.
Thank you. All right, guys. Great job.
Thank you.
Thank you.
Thank you.
Hopefully helpful.